everybody, and welcome to this episode of Conversations in Health and Healthcare Excellence. My colleague Amar Shah and myself, Pedro Delgado, are delighted to have a set of guests that are going to try to unlock for us and perhaps even simplify with us the amazing opportunities and increasing also challenges and complexities of artificial intelligence and its wonders and quality specifically. So as we navigate into a future packed with opportunities to improve processes, improve outcomes, improve the quality of work and the quality of life of those that work in the healthcare system, we are trying to understand how to do this best, and we have three amazing people to join us and reflect with us on where things are, where things might go, and what they're learning in real time. So, Amar, over to you.
Thanks, Pedro. Really excited about this conversation we've got lined up today. Artificial intelligence is such an important aspect of the future of health and care, isn't it? So merits not just one or two guests, but three guests with us today. I'd like to introduce, first of all, James Hoffman, Senior Vice President for Quality and Safety at St. Jude Children's Research Hospital in Memphis, Tennessee. James, welcome to the program.
Hi, really glad to be here. I guess just opening thoughts is kind of where my interest came in this topic is for a long time, I've always seen the connection when doing quality and safety work with kind of information services, analytics. Like, to me, you can't do quality and safety without that connection. And so it's just been natural to try to learn and understand how AI fits with doing quality and safety. So that's kind of what I bring to this conversation.
Fabulous. Thanks, James. Our next guest is Paul Sharrock, who's the Clinical Professor of Pediatrics at the University of Washington and Vice President and Chief Quality and Safety Officer at Seattle Children's Hospital. And Paul, you are joining us this morning from Hawaii, where it is 6 a.m. and you're on vacation. So big thanks from all of us that you've made the time on your vacation to join us for this conversation.
Indeed, aloha everybody and good morning. Thank you for having me. As Amar said, Dr. Paul Sharrock, I'm a hospitalist by training, and jumped into this work, as you heard from my title, as Quality and Safety Overseer at Seattle Children's and previously Stanford University. In the late 1990s, when To Err is Human came out, I was a fellow at Stanford, and what turned out to be, it was health services research, but really turned out to be more quality and patient safety focused, and really began an early career as a patient safety thinker and researcher, and soon thereafter met Dr. Chris Longhurst as a resident there. And I began to really understand, with his background in informatics, the power and opportunity of leveraging informatics and electronic tools, if you will, to transform quality and safety outcomes. So that's my interest here, and obviously AI would be the next generation of that thinking. So thank you for having me. Again, look forward to contributing.
Fabulous. Thanks, Paul. And you've already introduced our third guest today, Chris, Chief Clinical and Innovation Officer at UC San Diego Health and Exec Director at the Jacobs Center for Health Innovation, Professor of Medicine and Pediatrics at the School of Medicine there in San Diego. Chris, and global expert in the field of AI in healthcare. So really, real privileged to have you with us today as well, Chris.
Well, thank you very much for having me. Like Dr. Sharrock, I'm also a pediatrician and work as a pediatric hospitalist, and I've had a passion for quality and patient safety since learning under my mentor, Dr. Sharrock. So it's a real privilege to be here today with Dr. Hoffman, Dr. Sharrock, and looking forward to the conversation.
Fabulous. Pedro, you started us off by framing this as perhaps starting with some simplification. This is such a field that, some people feel is too technical, too tricky, too vast to really make sense of or even tiptoe into. Where do you think is a good place for us to start this conversation, Pedro?
So I'd love to hear Paul, Chris, and James, and what a wealth of experience. By the way, amazing places that you're in: Hawaii, San Diego, Memphis. Amar, I think we probably need to go and visit them at some point soon in each of the three. I'd love to start with the low-hanging fruit. So, Chris, Paul, and James, if I was greedy enough to ask you this, if you were having a conversation where you were trying to frame for someone that's starting on this journey of adopting and adapting some of the best of artificial intelligence into their working quality, what would you tell them are some of the low-hanging fruit, the stuff they can start doing tomorrow? So where would you start? Structure, simplification of notes. How would you frame it for them? What would you say? I'm really curious to hear your quick reflections. And maybe we can start in Hawaii to go farthest west, and then we'll go to San Diego, and then we'll land in Memphis.
Okay, interesting question, Pedro, and thank you. There are some obvious areas that are gaining traction in AI and healthcare immediately that are having immediate dividends. An area relevant to patient safety, I'd say in particular, is around impacting clinician burnout. There's a lot of literature suggesting that clinician burnout, nurses, physicians, et cetera, directly negatively impacts patient safety outcomes, everything from infections to delayed decision making, et cetera. So anyways, there are lots of opportunities for improving efficiency, such as helping with daily notes for our physicians. So we've seen that you can decrease the amount of time that you're writing notes as much as an hour or two a day for clinicians that are leveraging ambient AI to help with that.
Sounds brilliant. Chris, how would you follow that?
Well, I think Dr. Sherrick's exactly right that clinician burnout is a clear impact on safety, and we're all excited about the opportunities to use these new tools to impact burnout. I think there's also some more direct connections to quality improvement and patient safety that we'll see drawn over time. So for example, as we roll out these AI scribe tools that Paul is alluding to that may save clinicians a lot of time, they may also be able to provide things like diagnostic decision support, which is sort of a holy grail for health informatics. And we know that missed and delayed diagnoses are actually part of the hidden iceberg from a patient safety standpoint. They're the leading cause of medical legal lawsuits and settlements in the United States. And so anything we can do to help decrease diagnostic errors and improve diagnostic accuracy is clearly going to positively impact patient safety. All that being said, I want to take a very thoughtful kind of look at these tools and recognize that while there is emerging literature, it's not all positive. In fact, we've seen just in the last 60 or 90 days, several articles out of Advocate, Stanford, and elsewhere really questioning whether these scribes are having all of the sort of positive impacts that the press releases suggest. And in fact, the Advocate study is one of the largest and suggests that outside of primary care physicians, there was very little time savings, although it did positively impact the physician's experience. And so that's a good thing. It's a reason to continue expanding and scaling these tools, but we also want to make sure that we're realistic in terms of our expectations. Here at UC San Diego, we were one of the first health systems in the country to roll out draft responses to messages from patients in the MyChart inbox. And we were really optimistic this was going to help our doctors save time. And what we found was that it didn't. Before the AI tool, it took about 30 seconds for a primary care doctor to see a message and type a response or use a dot phrase. And after the AI tool, the draft message took about 30 messages at 30 seconds to read through because it was 3 paragraphs long now. And editing that to be consistent with your tone and maybe accuracy also took about 30 seconds. So a busy primary care physician getting, let's say, 30 messages a day, still spending 15 minutes, even with the AI tool. But we know that the messages they sent were 2 to 3 times longer, were perceived by the patients as being higher quality, and our physicians reported less cognitive burden, and in the Stanford cohort, they reported decreased levels of burnout using a validated tool. So these are really important and helpful tools, but I think we're early in the rollout, and like any evidence-based clinicians, we should take a skeptical eye towards the ability of these tools to really impact the problems we're trying to solve.
What a beautiful way of giving us the two sides of the coin. You know, I think what part of the danger we have here is overhype and overexcitement about something that truly is trailblazing. Like you guys are doing stuff that's never been done before, literally. So the fact that you're taking such a scientific view of understanding the impact and so on is absolutely brilliant. So thanks to both of you for your initial reflections. James, what would you add?
I would add that besides the kind of patient care process, the clinicians doing the daily work, I've been thinking about these tools from the perspective of the quality and safety team, the quality professionals. So, how do these tools help do an improvement project faster and better, and are they a resource, and how are they best used as a resource in the midst of doing improvement work? So I'm trying to learn there, and we're trying to kind of experiment of, does it help a team brainstorm and kind of define their aim? Another thing that I'm really interested in is, looking at patient safety events, and you might get a lot of events, but can the AI tools sort of comb through the events and summarize and find things that may not be obvious, or may bring together trends that just aren't done with kind of current analytic tools. So I think about this a lot in terms of people doing quality and safety work day in and day out, and teams collaborating, and how can it help them do their work better? Because we know there's always opportunities to do more for quality and safety, and there's always that kind of prioritization that has to happen of the resources you have available versus what you can get done.
Yeah, and Amma, before kind of passing the ball over to you, I want to underscore the beauty of the work in St. Jude's, that it's both local and national in terms of the work that you do in Memphis and across the US to support research, and in Memphis to provide care, but also global. And I think that global network that you've been building through St. Jude's Global is an amazing opportunity to try to start to transfer some of this early learning into over 300 institutions that you have already befriended across the world in some pretty formal ways to improve cancer care for kids across the world. So congrats on that opportunity. Amar, back over to you.
Thanks, Pedro. Thanks, everyone, for the reflections on low-hanging fruit, where we might start. James, I think you're absolutely right. One of those places is for improvers to think about how we can use generative AI in speeding up or making richer some of the processes that we use in quality improvement work. And you and I have been exploring that. We presented at the last IHI forum and are going to do that again at the International Forum later this year. All three of you are struck really frame this around a problem you're trying to solve, not as a solution, but really thinking about the problem first, whether that's about reducing administrative time, whether it's about reducing burnout. And that's obviously very aligned with the principles of improvement, isn't it? Really being clear about the problem we're trying to solve. And another principle of improvement is about testing, adapting, and learning. And I wonder whether you might give some advice to people who might be listening, whether they are practitioners who want to experiment with this in their practice, or for those of us who have influence at organizational level and are thinking about introducing this as at enterprise level. What advice do you have about steps to take in terms of safely testing, adapting, and learning how this technology might be useful in solving a problem? What have you learned about steps we could take to really take a testing and learning approach? Chris, do you want to kick us off with that one?
Sure, great question, Amar. I think a basic tenet of any quality improvement effort is what you just described, which is testing and validating and looking for results. And those PDSA cycles are still critical regardless of the tool that you're using. And so at UC San Diego, we've taken the approach that AI tools that have been shown elsewhere to have some impact or work are really being implemented under a quality improvement mantra. And so we use quality outcomes kind of resources to help analyze those. And I could show you our Acquire committee, which aligns and coordinates QI research and evaluation. And we probably got 14 or 15 different AI initiatives that are supporting quality improvement that are active right now. And for each of those initiatives, we're trying to measure those outcomes. In other cases, they're really unknown. For example, I had a call yesterday about opportunistic screening for heart failure using EKGs because there's some early data suggesting that AI can help identify previously unrecognized heart failure. But of course, there's a whole care pathway there that needs to be put into place, and how we do that is uncertain. And so as we undertake that, we're actually going to do that under IRB as a clinical research study because we want to know, can it actually impact outcomes? We don't know from other sites that there's evidence that it can. And so I think particularly in an academic medical center where we view ourselves as a learning health organization, the key thing is whether it's QI or clinical research, that we're really studying the outcomes to understand, is there value? Is this worth our investment?
Great advice, Chris. James, what about your learnings about trying to introduce this in St. Jude? What might be some transferable learning for others?
Yeah, I think one starting point for us at St. Jude is I think and I think continuing with the theme of how do these tools help with daily quality and safety work. As an organization, I think we're kind of grappling with how do we scale these tools? How do we do it properly? How does it insert into daily work? So I've been spending a lot of time collaborating with information services and analytics groups as they're sort of building out that framework. And what I have in mind there is, as these tools get into all of St. Jude's work, then I have a platform to say, okay, when you're doing improvement work, this is how it fits. So it's a bit of a process, but that's part of how I'm approaching it. And then I think there will be tactical things that I have in mind that I can layer in with our standard improvement methods and the toolkit we've been developing. So, for example, that idea of a chatbot helping a team do improvement work, I'm imagining like a kind of like prompt library and some how-tos that some people are not familiar with working with a chatbot, and this could be like their first experience. And so how do we sort of train people, guide people to say, look, these tools are new, but we think they have some value. Will you try them out? And so I kind of working at the organizational structure and then working within kind of my purview of the improvement methods, kind of working at both levels.
That's great. And I imagine there's some lower risk data we could start working with, chatbots to help people learn, and interact with clinical protocols without reading hundreds of pages, as an example. Patient portals, which might guide them to what's available as a next step for their, intervention.
And just like teams brainstorming and that kind of thing. I think it's really fascinating. Of so many times, I think the paradigm is, they're going to replace, AI is going to replace, and it's this scary thing. And I think there's this other line of thinking of like, no, the AI can prompt people's thinking and change the way a team might approach a problem. And so that's part of it that I think is really fascinating, because there's this scary element to some people, and it's like, just try it and see, it's a tool, try it out.
Well, what about your experience at Seattle Children's?
Yeah, thanks, Amar. Great question, and I love the answers from Chris and James. Well, I'd say Seattle Children's is, I think, philosophically almost a fairly risk-averse organization in general. So we've launched our AI work largely, if you will, outside of the direct patient care environment. So, for example, several of the initiatives we're working on have to do with better coding in our charts, or elements of efficiency, as I mentioned, et cetera. So I think that approach has been comforting, I suppose, to not only our organizational leadership, but frankly our faculty and staff as well, is that we're testing the tools in environments that are going to be very low risk for our direct patient care, but still could and will have some direct tangible outcomes in general. Chris had mentioned also some of the real basic concepts of quality in his answer. And I think just reflecting, always having balancing measures as you're carrying out your QI work is good improvement science rigor. I think we need to remind ourselves of that as we sally forth with these really fun and fascinating and amazing tools. So I say sticking to improvement science rigor and ensuring that you're measuring a cadre of outcomes to ensure that it's a healthy intervention is just good QI science. An interesting example of some of that early AI work we're doing has been just simply attempting to translate into a series of different language or discharge instructions for our inpatients. So leveraging that tool rather than using our translation services, for example, to help with that. And in validating that work, we learned that essentially, with the exception of Spanish, at least with our environment, none of the other languages translated well enough or accurately enough for us to feel comfortable using. So that may be an interesting practical example of how it makes total sense that AI should help us with Somali just as much as it should with Spanish, but in reality it didn't. And so we're limiting our work right now just to Spanish translation and figuring out how to get better in the other 100 languages we use.
Really interesting, Paul. I'm hearing across all three of you to really be mindful about risk appetite, to think about the kind of data that we might be prepared to experiment with, and then also to really apply the rigor of either research method or improvement method to make sure we're clear about outcomes and that we're able to demonstrate efficacy and that it's value adding.
Amar, I think that's exactly right. And, I think that the question really isn't where has AI been demonstrated to conclusively improve patient safety or quality. The question is more, where can you as a learning health organization test those questions? Because this is very early. And despite what the vendors would have you believe, there really aren't any large studies or conclusive outcomes yet. And we're all really enthused about the opportunity. And I'm quite certain in 5 to 7 years that this is going to transform the way that we approach our work. But I don't think that we have the data yet to clearly guide us on where those investments should be made. And in the absence of that data, in some respects, it's almost unethical to spend large amounts of money on these tools, which would be easy to do given the cost of the cloud compute. And I think instead, as James and Paul described, collaborating with others, learning from each other, and then taking these small steps towards here are processes or outcomes where AI can really help drive improvement.
I'm going to hand back to you, Pedro, now, but I'm still lingering on Paul's comment about language. And I just wonder whether, Pedro, there's something about an equity dimension to the use of generative AI that you might want to pursue with us, Pedro.
Yeah, it's one of those topics that I think at times keeps us awake at night. And I'm probably speaking for all of us. I'm definitely speaking for myself. And I know from Amar's work in health on equity, it's a topic. In addition to language, and then I have a 3-part question because I'm being a bit greedy. In addition to language, what else are you guys considering in the domain of equity as you continue to test and learn about the potential and of the tools of AI in terms of quality? In terms of equity, Paul, you started us off by alluding to language. What else should we be thinking about proactively so that we don't unintentionally, you talked about balancing measures, Paul, continue to leave people behind in terms of access, experience, and outcomes, for example? What else would you consider in terms of equity? And Chris, you started us off the second time. Paul, you did the first time. So James, I think it's your turn. We're trying to be equitable here.
Okay, sure. I think one dimension that maybe doesn't get enough attention, and building off what I heard Chris say of where do health systems make investments? There's an equity dimension of this that I worry about in terms of the different resources that, like in a US context, vastly different resources, health system to health system. And I'm concerned that larger health systems with more resources have the ability to test and try these tools. And if you share Chris's confidence that 5-7 years these are going to pay off, and I share that confidence, are we headed towards a divide by health system because some health systems have the resources now to get going, get trying, learn, make the investments, and others just aren't able to, and they have other priorities. So that's the first thing that comes to my mind of this kind of organizational structural inequity that could develop, just with who can stand these things up as they start to show value.
Oh, what an amazing thought, James. What an amazing thoughts, and the farther you look into the world, especially in low and middle income countries, that becomes an even bigger issue. So what a good frame to consider. Chris, what would you add? And then we'll circle back to Paul to see if he wants to add to his initial spark around language. What else would you add around proactive equity considerations at this stage?
Yeah. Well, I'm going to use an example here from UC San Diego, and then I'm going to respond to James' comments, maybe with a slightly different perspective. So when we were rolling out one of our machine learning-based sepsis early identification tools, we had some really interesting findings. We built the algorithms based off of our local data. We, at the time, had 2 hospitals, one that serves a lower socioeconomic area, one that serves our La Jolla area where we see more sepsis from cancer patients, et cetera. And it was a really profound impact of this tool that we published last year in Nature, showing an almost 18% reduction in mortality. But when you read it deeply into the manuscript, you'll see that we saw about a 12% impact here in La Jolla and almost 24% impact in our other hospital in Hillcrest. And in fact, that was because the tool was helping us to close gaps in health disparities. We didn't do as good a job as identifying sepsis early in our population of patients at this other hospital where they were immunocompromised for other reasons like HIV. Their average age was younger. It was harder to identify sort of a classic, picture of sepsis. And so we actually have that data in press now because it's an example of how AI can be used to help close gaps in health disparities, which is, of course, what we all want. So then if you pull the stick back, James' comment is spot on about, hospitals that are making these investments, may accelerate, faster than hospitals that don't have the resources. But Zach Kahani recently published in the New England Journal a wonderful perspective piece called The Healthcare We Have. And his point was, as we test these AI tools, we can't be comparing them to a perfect gold standard. We need to be comparing them to the actual healthcare we deliver today, which, as we all know, is frequently imperfect, right? And I think the same is true of these AI tools. We shouldn't be stopping these investments, right, at the health systems that have these resources, because this is how we all move forward. And in fact, if we compare to current state, AI may exacerbate some of this, but the reality is there's a lot of disparity today because of the differential resources. And so it's actually incumbent upon us ethically for the hospitals like St. Jude's that have tremendous resources to invest to learn so that all health systems and all patients can benefit from it. So that's my slightly different kind of ethical lens on this. I'm less worried about exacerbating disparities and more worried about us not moving forward and learning as quickly as we possibly can. And then my final comment, because this comes up a lot in Congress and policymakers and other things, is what about these other health systems, that can't afford the FQHCs as an example? And my response is, gosh, you guys, what scales better than information technology, right? There's 6,000 hospitals in the US. We have about 3,000 hospital CEOs, which means there's about 3,000 hospital IT departments. And to date, every children's hospital and most academic medical centers have been running their own IT departments, right? And yet we see this trend over the last decade towards larger and larger instances, right? So we now have electronic health records serving, 50, 100, 150 hospitals. In the country of Australia, the whole state of New South Wales is putting in a single instance of an EHR. And when you pull resources at that level, let me tell you, you can do things that even we as well-resourced academics can't do, right? And so back to the federally qualified health centers, did you know 1 in 3 FQHCs now sit on a common instance of Epic that is hosted by OCHIN, which started as the Oregon Community Health Information Network. And I'll tell you, OCHIN's doing amazing things with AI, and they have, as many resources as we have here at the University of California. So I'm really optimistic about the future, and I just think that we've got to take an ethical lens that we're obligated to learn as quickly as possible to benefit our patients.
Well, what an opportunity and what a responsibility too, in the heads and shoulders of healthcare professionals across the U.S. and across the world. Paul, you've heard two really interesting responses to the equity framing. Anything to add from your perspective about possibilities or challenges?
I do, thank you, and let the record show I hate speaking after Dr. Hoffman and Dr. Longhurst. Those are tough acts to follow. So reflecting back on my home institution, Seattle Children's, we have a profound, rich legacy of reflecting on equity, disparities, etc., and done a lot of work in the space. And I have a couple thoughts. One is we can and should, we're obligated to always measure our outcomes and stratify by race, ethnicity, and language for all of the outcomes that we track. So whatever intervention goes into play, whether it be AI or another, we need to understand the impact, the differential impact it may have on different races or languages. And we see this all the time. So I'd say that's a foundational element in my opinion around the equity space, is to always be measuring on those strata. The other thing I might add is I know the literature is frankly full of research and studies that historically have been and are biased, right, in ways that we do not know necessarily. All that we know is that they are. How they got that way, et cetera, is a different story, I guess. But, AI models gather information from the literature and the information that's available to them, and then in turn creates content based at least in part on what knowledge is already out there. And if you're starting with biased information from the get-go, it's potentially only going to be amplified. And I will tell you, that is, I would say, one of our biggest concerns at Seattle Children's, in an organization that really closely pays attention to disparities and attempts formally to eliminate everyone we see. This is a huge concern of ours. An example, a little outside of the AI space, but as we put together a series of, I think we have about 75 clinical pathways now. We have a very rich legacy of a decade or more of very high-level, exceptional pathways for different pediatric illnesses. And what we learned is we built those pathways in large part on the literature that was available to us, the best practice at the time. And what we learned is, at least sometimes we ended up, by using that best practice literature, reinforcing or exacerbating disparities because of the biased nature of the literature findings. And again, we didn't know that, of course, but as we tracked this is the key point, as we tracked the outcomes and we looked across the domains and the different strata, and we realized we were making things worse for certain populations. So these are the things I really think about in terms of the equity space that I think AI has the potential to really influence. Hopefully in a positive way, but there's also real risk, as we've all talked about.
Thanks, Paul. Amar, I'm about to pass the ball over to you, but I can't help, because this group has been so pragmatic to ask a three-way question, but ask each of you to answer only one bit. And the three, and we'll start with you, Paul, only because you said you love to go after Chris and James, and we're going to try to avoid that. So a moment of awe, something that you thought, wow, my goodness, how the hell are we doing this? But we did it because we're using AI to improve quality. So a moment of awe. The second one is a must as you start or as you continue to do this work. So you must X. And the third one is an absolute no-no. As you do this work, just don't do. So Paul, you get the choice to pick one of the three angles.
Okay, I will. I'm going to pick the we must X. And this is a reflection on a conversation we had last week at my executive leadership team, our executive team, as we meet formally on a weekly basis. We heard our AI strategy described by our CMIO and our CIO. And in that mission statement for the AI strategy, the first thing mentioned as why we're doing all of this is to improve patient outcomes. And as they described the early work ongoing, the investments we're making, et cetera, not a single one of the projects that were described, in my view, as the Chief Quality and Safety Officer, will actually have a direct impact on our patient outcomes. And I was struck by the fact that despite the goal of the work, there's seems to be very little tangible work ongoing to truly impact our patient safety and quality outcomes. I think Chris touched upon this a little earlier. And I mentioned earlier as well, is that we're dipping the toe in the water with efficiency and coding and improving our reimbursement rates, et cetera. But at the end of the day, none of that's going to really help our patients. And this is our work. This is what we do or spend our lives doing. And this is our jobs collectively as the three of us. We have to start really thinking about the interventions that are truly going to impact our patients. So that's the must do.
Brilliant. Chris, you've only got two options here. So moment of awe or an absolute no-no.
Well, I'm going to cheat a little bit, and I'm going to say I'll take the moment of awe, but I'll start by agreeing with Dr. Sherrick that we want to focus on outcomes, and also agree with what he didn't say, which is that AI governance is an absolute must-do as you're proceeding. The moment of awe for me has been the ability of these tools, particularly generative AI, without pre-training, to have huge impact. I'll give you two examples. One of them is that if you think about all the text we have, obviously, the notes in the electronic health record are obvious substrate for generative AI, for chart summarization and other things. But we're starting to test things such as, can we review a clinical chart and identify whether standard of care was met in all cases? And that simple prompt can completely transform how we do peer review today. Right? We've been looking for years for those triggers that would allow for consistent review of X% of charts in a given service. And it's been really hard, particularly in the adult world, to find those triggers in surgical services and procedural services and other things. And we're finding that generative AI may be an approach to consistent peer review that could just absolutely transform the way we think about ongoing improvement. And then the second example is, let's not just think about text, let's think about video and audio and other things. And of course, there's a lot of excitement about the AI scribes and helping efficiency, and it remains to be determined how much that will prove out. I'm really excited about using video in the smart room in the patient hospital to help improve safety. Imagine today we use these devices that you put under a mattress to help remind nursing staff or patients who are at high risk to ensure they're turned so that pressure ulcers don't develop. We pay a ridiculous amount of money on an annual basis to this vendor. Could cameras in the room identify patients who aren't turning and need to be turned? Yes, absolutely. It's been shown. And in fact, if you put those cameras in all rooms, you no longer even have to differentially apply those kind of tools only to patients you perceive to be at high risk. Because actually the highest risk patients are the ones who aren't monitored, right? And could those cameras then also do other things in a safe, respectful, private, and trustworthy way, like identify patients at risk for DVTs and ensure they're getting appropriate prophylaxis? Could it identify hand washing compliance and help improve that? So back to Paul's point about that direct link to safety, I'm blown away about where we're going to go using generative AI for video feeds, and using generative AI for chart reviews and even for our incident reports themselves and identifying trends that today are difficult to identify except in retrospect when we have a bad outcome and realize there have been 7 different reports that were filed by 8 different people and reviewed by 5 different quality analysts and nobody put that picture together. So that's my moment of awe.
Amazing stuff. I mean, seriously, it's mind-blowing. James, so what remains here is an absolute no-no. Before we hand it over to Amar to help us kind of wrap up, bring us home, maybe ask one last question. Go for it.
Yeah, I'll try to I'll try to pull 2 threads that have kind of been discussed. I would say um, I heard, fix real problems, understand real problems. So I would say do not just do what is cool because it's cool technology, fix problems. And then Chris mentioned governance, and I think this connects, and some of our experiences it connects is, you know, don't do this without structure and without a thoughtful approach. And I guess those two connect in my head because I've been part of a small group kind of helping to stand up our, I think we've called the group Clinical AI and Predictive Analytics, and it's very much scoped for anything that's going to go into patient care at St. Jude. We did a ton of background work, writing the charter, writing the, thinking through the right people and where does it report. And it was really, in a way, quite gratifying that we had kind of the kickoff meeting last year, and people really spoke up to say, well, wait, what are we trying to solve? What does this technology bring to what we need to do to improve care at St. Jude? So that was really gratifying to see.
Thank you all. This conversation has flown by. It's been fascinating, and the insights you've all brought have been super helpful in untangling what could be a bit of a minefield for us. You've given us some really sage advice around where to start, what we should be considering, how to really bring some rigor to the way we introduce and evaluate this. I wonder if we might just finish off by asking you each to reflect on the future, just in a sentence or two. If Pedro and I meet with you all in 5 years' time, if we were to reconvene, January 2030 it will be, give us a reflection on where you think this field will be 5 years from now. Chris, you want to kick us off? Where do you think we'll be?
Sure. I'm going to be a little bit provocative, and I'm not sure if it's 5 years. It might be closer to 7 or 8. But one of the questions that comes up frequently is the legal implications of using AI. And it's been well established, clinical decision support tools are adjunct, to help with clinician decision making, and that ultimately it's still the scope of practice for physicians who are accountable for the outcomes that they, or for the decisions that they make. However, I think that over the next 5 to 7 years, we're going to see so much data emerging showing that clinicians working with AI is superior to clinicians working without AI, that the legal precedent is going to change. And I think in, let's say, 7 years, it may become actually a standard of care for a physician to be using an AI copilot in diagnosis and treatment decisions. And that it would actually become almost malpractice to be operating without that. So that's my first sort of provocative prediction. I'm going to go a step further. I'm going to say in 10 years, we're going to see an AI copilot that's actually licensed to practice medicine independently. And I think mental and behavioral health will be where that starts. So those are my provocative predictions.
Goodness me, that's definitely kicked us off with some provocative, compelling visions of the future. James, how do you follow that? What do you think? Where do you think we'll be in 5 years?
Well, I'll go back to my interest in the quality and safety professional or the team doing their work. I think that without some directed kind of coordinated effort, those kind of uses will lag all the kind of clinician workflow, everything that Chris was describing. So I I want to be optimistic, but my kind of current assessment is 5, 7 years, we'll still be looking, saying, wow, they do this great thing, like the things Chris talked about, but it's really not embedded to how we look at patient safety events, or it's really not embedded in how teams do improvement work. So I think objectively, that's my assessment, that it's that daily quality and safety work is going to lag other uses in healthcare.
Yeah, thanks, James. That's a pragmatic view, isn't it, about where the investment's likely to go,
exactly,
and where people are likely to start first with experimenting. And Paul, before we leave you to head back to your Mai Tais on the beach, where do you think we'll be in 5 years?
Well, it is only 7 a.m. here, so I'll probably hold off a little, maybe in an hour. Chris, again, he stole my thunder, because I wrote down right away, it's like, clinicians using AI will completely replace clinicians that don't. They'll be antiquated, right? Those that don't know how to use this. To me, it's almost like not knowing how to use a stethoscope. That's what it's likely going to be in 5 years. But thanks, Chris, for stealing that. I think I'll go a different direction slightly. So I mentioned I was a fellow at Stanford when To Err Is Human came out. And I think we all know that ignited the patient safety burning platform and has transformed medicine ever since. I was very fortunate and blessed to be asked by Don Berwick and the IHI leadership in around 2010 to evaluate where we are 10 years later. And so ended up publishing a study eventually in the New England Journal of Medicine that essentially showed 10 years later, we made virtually no impact, looking at using a very sophisticated trigger tool model to identify harms over time. And that wasn't really met very well, of course, by the press or by the IHI, who, of course, was doing great work to try to decrease harms across the U.S. The 100,000 Lives campaign, the 5 Million Lives campaign, et cetera. In some ways, we're not having tangible impact on outcomes. David Bates just replicated that methodology essentially and published last year, or maybe 2 years ago now, 18 months ago or so, that essentially we haven't made much of a dent yet in patient safety. So 20 years now after the burning platform, and just an endless stream of investments and regulations and visibility and transparency and law, et cetera, and we haven't cracked that nut yet. So I do believe that AI and the tools that we're talking about here have the ability to transform that outcome. Is that I think 5 to 10 years from now, we are going to look back and finally say we have finally made a true impact on safety outcomes. That's my hope and dream for sure, and I certainly see this as the clear front runner in ways we're going to have that transformational impact that we have not been able to have in 20 years.
Fabulous. Thank you, Paul. Thanks, Chris. Thanks, James. What a rich discussion, Pedro. Your reflections, then we'll wrap up.
My reflections are hope, opportunity, and rigor and responsibility going hand in hand. Paul, Chris, and James have reflected with humility, actually, on their experiences, on the discipline of creating a little bit of structure to learn in an accelerated way about how to best adapt and adopt some of these emerging tools. And I hope that your vision jointly, Paul, Chris, and James, of accelerated learning and ongoing collaboration in a really, really open, transparent, and agile way comes to fruition. And I think Amar and I share your view that in 5 to 7 years, we'll see a pretty different world, packed with good impact, good possibilities, and those possibilities not just emerging, but having been realized and leading to others. So maybe we'll be talking then about what the next 5 to 7 years will bring, which will be another curve. But Amar, what a privilege. That's the sense I'm getting here of learning together. These guys are shaping the future, and it's exciting to be in this space with them and with you. So hand it over to you to bring us home.
Thanks so much, Pedro. Thanks, Chris. Thanks, James. Thanks, Paul. What a fantastic conversation. Really appreciate you sharing your insights with us and with our listeners. For those of you that have been listening in, thanks very much.